Next topic, we would like to invite Dr. Do Văn Chien from a military hospital to present about the left main intervention with drug corticosteroid, when and why.
Thank you. Good morning, everyone. So we have 10 minutes to talk about this one. I have to do it quite fast. And to answer the question from Dr. Quan Lee is that now in Vietnam, we are using drug-coating balloon is more and more. And we have gaining more experience in terms of using even in left main cases. So I'm trying to use my chance to present my case. So my quite old patients, 85 years old male with a past medical histories of hypertension and multiple GI bleeding because of the upper GI tract ulcer. So the patient come to us with a very severe conditions, respiratory failure, SpO2 88% and hypotensions. So you can see on the EKGs as the elevation and AVR and multiple depressions showing you that's very large ischemia. So the echo showing the EF ejection only 45% and the lactate is 3.6. So the diagnosis is QMI with ST elevation in AVR and complicated by cardiogenic shock. This case is very specifically because it's a high bleeding risk. So this is the angiography. As you can predict in the EKGs, the left main already occluded, but luckily this patient have a huge RCA, so it's supplying the collaterals to the LAD, showing that this patient can survive in these very severe conditions. So because of the collaterals quite big, and we are thinking what we can do. So this is, you can see the radiant access for the diagnostic angiography. For most of my cases, I ask myself what I can do for these very complex cases. So I changed to the groin because I want to use a bigger guiding catheter, 7 French EBU with a femoral access. And the guide wire, I don't know where to go. Just go and anywhere it should go. And you can see that it can cross the left main because the condition is quite severe. I try to put the balloon fast as possible to restore the flow. So I use a balloon Ikazuchi 2.2 20, and after that I diverse. And you can see that I can put another second Y in the circle, and this is a quite a small circle and very tortuous. The left main is long and diffuse disease. As I said before, I tried to do it as fast as I can. I use my Scoreflex balloon 3.010 and I deployed high pressures trying to restore the flow. And after the restoring the flow, I apply the DCB in this case. And you can see the flow after this is quite okay. Luckily, these patients return to the blood pressures increase quite fast after procedure. You can see no matter is small, but the effect is quite good. You can see the IVUS pre and with the MLA about 6 mm, and after that we can get to 9, and the flow is quite good in terms of this case. So the patient reduced chest pain very fast and hemodynamic improved. Vessel pressure will stop on the next day, discharge after 1 week, and we are planning to do the CTO intervention if symptoms persist. Actually, this patient, I invited him so many times to come to our cath lab to do CAG as Dr. Chazang said, but patient said, I'm okay, I don't want to come and I want to do anything else. So let's talk about the left main BCI in the very large SCAR registries in Vietnam as well as in many other countries. We don't have RCT for the DCB in many circumstances, but we do the learn from the SCAR from Switzerland. As you can see in this slide, the left main they didn't do so many, only 2.5 cases, over 500 cases, and in the DCB with the other bucket and sirolimus, 5.6 cases over 1,200. After 2 years, the number also decreased from 2,000 cases. They did only 1.6 cases percentage, not so many. Also in the 5,700, they did only 2.2%. So most of us, we did the same for the left main intervention. In this slide, I show you why we did differently in the left main interventions. We put two wires in the LED and the circs. At first, we try to restore the main flow because it's most important things, as I demonstrate in my case. So we put the stent in the main vessels. And after that, we rewire and put the DCB in the side branch. Is most important things because some people will do the inversely, like DCB first. I think most of the cases we do the same. We did restore the flow first. And in case if we use too big DCB, we can cause a dissection, as Dr. Inghan said before. We can leave it with restenosis and less than 30% and flow is okay. In case there's a dissection more than type C, we can seal it with a stent below. So let us look at the results of DCB in 200 cases, hybrid DES with DCB, and compare with the DES, either provisional stent or two-stent technique in 400 cases. As you can see on the left-hand side, the graph showing that the red line is lower than the blue line, meaning that the hybrid approach is better than the DES. It's the same in my clinical practice. In most of my cases, I'm doing the same. I simply my cases by using the provisional stent with DCB. If you don't want to do the DCB, DS together with DCB, can we do the DCB alone only? Let's look at the results here. You can see the very complex case, the left main bifurcation, trifurcation, as you can see. They have a study in China compared to about 217 patients. Among them, 40 patients with the DCB and 100 patients with the DES. After almost 2 years, they compare the DCB hybrid with the DS, but the on-call mortality and cardiovascular mortality is the same between them. So this is my last slide, take-home message. Why there's sufficient evidence for the use of DES in left main, but there's paucity of data exploring the role of DCB in the de novo origin in left main. The studies comparing DCB only angioplasty for de novo left main disease with the second generation of DS may be ongoing. We don't know yet. But our case demonstrates that the safety of DCB angioplasty in our institution is suggests that DCB only strategy could be considered as alternative strategies to DES in experienced center, particularly for individuals that are at high risk of bleeding and long-term of EDABG. With that, I thank you for your attention.
Yeah, thank you so much for that fantastic lecture. It's clearly a frontier here. You know, there are so many permutational combinations that you can imagine, especially as we move towards the possibility of a DCB-only strategy in the left main. Clearly, we are not going to have many answers for many, many years, because one question I had for you, when you do a 1-1 or 0-1-1 or 1-1-1, and you use a DCB-only strategy, do you use 3 separate balloons for LAD circumflex and then left main DCB, because the sizes are all different there? Or do you try and limit it to, you know, like a crossover of some sort? What do you end up doing in those situations?
Actually, usually I don't complex my case like that. I just use sequential.
Sequential.
The LAD, the circ, and the OMs depends on what the result I can get after the IVUS. Usually for the left main or the proximal LAD or proximal circ, I use IVUS in most of the cases. So depends on the result. I choose simple approach.
As simple as possible. All right.